Ready.
Okay. So the next presenter
Dear
is
respected Professor, my name is Jutikan Chinsuwan. I would like to be a representative
Wait.
research
Dr.
presentation,
Jutikan.
retrospective study of the
Dr.
accuracy
Jutikan.
of panoramic interpretation, the difficulty in surgical removal of impacted mandibular
It's okay.
third molar, comparing with actual surgical procedure. The most common surgical procedure performed by the surgeon is extraction of impacted mandibular third molar. That the panoramic radiograph is the most common technique used for preoperative assessment for the impacted third molar.
หยุดก่อนการเสียงบอกว่าแบบ
ใหญ่มากเลยค่ะ
It's okay. Please continue to present.
Traditionally, radiographic images of impacted mandibular third molar have been commonly categorized based on position in terms of depth and lemma relationship, as in Pale and Gregory classification system, and inclination, as in Winter classification system, for evaluation of removal hardship. In addition, Karma scale was used to assess the difficulty of preoperative surgical removal of impacted tooth. It was proposed in 2014 by Karma, which is separate in 4 groups, that is, angulation, depth, lemma relationship, and root form. And modified parent scale, there were 4 levels of procedural difficulty, as shown in the table on the right. After a literature review, the study of Alzheimer's in 2017 about the accurate prediction of difficulty index of prediction procedure by Karma scale was modified by modified parent scale was unreliable as preoperative predictor. Then this study had modified and proposed some factor which were different from an original Karma scale. Objective: determining the accuracy of prediction of difficulty index in surgical removal of impacted mandibular third molar by interpretation of panoramic radiograph using proposed modified Karma scale, and then comparing with the difficulty index of individual case with actual clinic procedure by using modified parent scale. We will discuss the material and method in the next section. Study preparation. Inclusion criteria. This study used good quality of preoperative panoramic film. Duration period between a taken preoperative panoramic radiograph and surgical removal was not more than 3 years. Available of treatment record during year 2019 to 2020. Have modified second molar. Have mandibular second molar adjacent to operate impacted mandibular third molar. Exclusion criteria. Patient who had pathologic lesion around impacted mandibular third molar which was observed in panoramic radiograph. Sample size. Using statistical calculation, therefore, a number of this sampling population must be studied at least 193 cases. Material and equipment. The panoramic radiograph was obtained by Pameka and processed by using Pameka Lomisis software. Method. This study modified the original Karma scale in the past of angulation in which mandibular of impacted mandibular third molar, which follow the Winter classification, that is mesoangular, horizontal, distal angular, and vertical, by setting an angulation in 3 groups and add a root curvature in the root form criterion for scoring at the difficulty index. For the modified parent scale, adjustments were made from the parent scale, where the difficulty index of procedural was divided in 3 levels as easy, moderate, and difficult. First, we will interpret the panoramic radiograph with modified Karma scale. Then we know the difficulty of mandibular third molar surgical removal. We compare with the correcting data from treatment record with modified balance scale. Then we know the relationship, whether they conform or not. Intercard correlation coefficients was calculated for confirming a statistical preciseness of operator measurement by using Cohen-Kappa statistical analysis. The ICC result was 0.982 according to an interpretation by using benchmark scale as reference guideline. The interpretation showed excellence. This research used data 16, where a p-value less than 0.05 or 95% interval was characterized by statistical significant result. There are only 50% were concordant in a number of pre-operative modified Karma scale and post-operative modified balance scale. Furthermore, Cohen-Kappa statistic of data 16 were calculated considering the benchmark scale as a reference and found that Cohen-Kappa equal 0.2313 and p-value less than 0.001. This value shows statistical significant difference in accuracy in surgical removal procedure from patient record. Thus, using of this proposed pre-operative modified Karma scale and post-operative modified balance scale for forecasting a difficulty in the qualify as fair. Discussion. The most uncorrelated results were 95 cases from 214 that preoperative modified Karma scale classified as moderate, difficult, but postoperative modified balance scale classified as difficult. This implies that the proposed preoperative Karma scale underestimated difficulty in the comparing to actual one. This may amplify by several reasons. First, due to individual experience, some surgeons prefer to separate wisdom tooth into pieces when confronting early curve, bulbar, or divergent roots for avoiding unexpected and unfavorable root fracture pattern. Second, the panoramic radiograph assessment is demonstrate only two-dimension anteroposterior aspect, which is insufficient to see the relationship of impacted mandibular third molar to the adjacent second mandibular molar in buccolingual aspect. Moreover, the improper length of skull in preoperative modified Karma scale may result in inconsistent with the modified balance scale. For example, it varies in distal angulation. Some distal angulation cases were classified as score 0 and 1, but some cases of my degree of distal angulation should have tooth resection because other factors like insufficient of space distally causing and obstruction of removal part. It was also found there were 4 cases from modified Karma classified as easy, but modified balance classified as difficult, possibly due to in dentist opinion that assess divergent curve bulbar root are more risk of complications as a result of the position of the tooth in the panoramic image is overlapping with anterior ascending lemma or external oblique lid. So we didn't know the actual location of impacted tooth. Therefore, modified Karma and modified balance scale should not be used alone in prediction of surgical removal difficulty, but may be used as a part of evaluation of the difficulty together with other factors that affect the procedure. It was also important to study other factors, whether it be patient systemic disease or surgeon appetite, and it would be great to study by using 3D image that make it possible to see the impacted tooth from another aspect. Thank you.
Thank you very much, Dr. Jutikan. Are there any questions from participants? We have 3 minutes for questions.
Hello. Can I ask some question, please?
Yes, please.
Okay. From the research, what would you want to improve for your future study?
Okay, because the result of the research are correct only 50%, other factors should be studied. It should compile more factors that will be affected, such as patient age, patient's BMI, angulation of second molar, number of loads, follicle development, and these factors should be testing before adjust gamma scale.
Okay, thank you.
Other questions? We still have time. Okay, I would like to know, so nowadays when you plan to remove the wisdom teeth, do you use this cutoff scale to assess the difficulty of the wisdom teeth before any procedure?
We just use some parts of this scale, just like angulation depth, like this, to assess before we do the surgical removal of impacted mandibular third molar.
Okay, and why you choose, because you said there's so many scales, right, to evaluate the difficulty of third molar. Why you choose comma and parent scale for your study?
From we reviewed the paper of Alsaman, found that gamma scale is unreliable with parent scale, and they inform that we should modify the scale to improve. So we modify the scale for make it more reliable.
Oh, okay. So the purpose to improve the sensitivity and reliable of the scales.
Yes.
Okay. So in your future that you said for further study with 3D, so is it better to use 3D with this scale together to
I think it will
assess
be,
the difficulty?
it will better because in 3D image you can see not only anteroposterior aspect, but you can see buccolingual aspect. Because some root is some angulation of root that we don't see in panoramic.
Okay. Because in 3D you can see all aspects. Okay. So it's better. Okay. Thank you. This is a very interesting topic as well. Thank you very much, Dr. Jutikan, for your lovely presentation.